Good afternoon and welcome to today's webinar, Benefits and Financing, hosted by the Blue Shield of California Foundation. This is the second webinar in a four-part learning series on local programs for the remaining uninsured. Our first webinar, held on March 30th, focused on program development strategy and local coverage programs. My name is Bonnie Madura and I am working with the Foundation on this learning series. I will be your moderator for this webinar. Before we get started, I want to go through a few housekeeping items. To avoid background noise, all callers will be automatically muted throughout the webinar. If during the presentation you would like to ask a question, please do so in the question window on your screen. We will do our best to address your questions at the end of the presentation. Also, just remember that today's presentation is being recorded and will be archived in the Foundation's website. Please tell your colleagues who were unable to attend so that they can still benefit from the presentation and discussion. Now, I'd like to turn it over to Carolina Gutierrez from the Blue Shield of California Foundation to say a few words. Carolina?
Thank you so much, Bonnie, and I'd like to also take a moment to thank all of our speakers on the call today. As Bonnie mentioned, I am Carolina Gutierrez, and I am a Program Associate with Blue Shield of California Foundation. Our foundation has supported efforts to address the needs of the uninsured through several changes to the healthcare landscape, most recently, of course, the Affordable Care Act. And as many of us know, the Affordable Care Act has significantly reduced the number of uninsured in the state. What we also know is that today and in the coming years, there will still be several million Californians who remain without health care coverage. And projections show that up to half of those will be undocumented immigrants. So in the absence of a national or statewide policy that addresses these persistent coverage and affordability challenges, California's counties have had to create individual approaches that meet the healthcare needs of the remaining uninsured. To help support these local efforts, last fall the Foundation awarded a group of grants to communities across the state in various stages of designing, planning, or implementing coverage programs for uninsured residents and undocumented immigrants. And in response to requests from this group, we have pulled together speakers who can elucidate best practices and lessons learned from their own experiences in focusing on coverage programs. As Bonnie mentioned, we kicked off this four-part webinar series on March 30th with a focus on developing the essential building blocks to get a program off the ground. And to continue the dialogue around program structure, today you will hear from three communities around the approaches they adopted in selecting the services included in their coverage programs and the strategies behind financing those programs. So I want to take another minute and just thank you all for your interest in supporting these issues alongside the fantastic partners that you will hear from shortly. And please enjoy this webinar.
Great. Thank you, Carolina. I'd like to take a moment and introduce you to our speakers for this webinar. First, we have Bob Brownstein, Director of Policy and Research for Working Partnerships USA. After Bob, we will hear from Cynthia Carmona, Director of Government and External Affairs for the Community Clinic Association of Los Angeles County. Then we will turn to Fresno, where David Palmaville, Director of the Fresno County Department of Public Health, and Norma Forbes, Executive Director of Fresno Healthy Communities Access Partners, will complete the discussion. With that, let's begin. Bob, start us off.
Good afternoon. I'd like to talk to you about the program that we've developed in Santa Clara County to provide coverage to those who are ineligible for the Affordable Care Act. And to do that, I think it's important to provide you with some background information about health policy and health advocacy in Santa Clara County. In this county for decades, both county government and health advocates have had a long-term objective of achieving health coverage in some way, some form, for everyone who needs it in the county. And that strategy, that long-term strategy, has had three elements. First, taking full advantage of those programs provided by the state and federal government like S-CHIP and Covered California that are available and can help with coverage expansion or insurance expansion. Second, creating brand new local programs for those who aren't eligible for the state and federal programs. We did that by pioneering through our Children's Health Initiative a local product, Healthy Kids, for essentially undocumented children back in the year 2000. And we also had a program called Healthy Workers, which was oriented towards small businesses with low-wage workers, which has since been supplanted by Covered California. The third step was to maintain a strong safety net for those people who did not yet have coverage, or in some cases coverage was available, but other institutions weren't particularly interested in providing care for people who had that kind of coverage. As we implemented this strategy, we developed an extraordinary history of collaboration between the county health and hospital system, community clinics, and health advocates. So we have been working together for a very long time. For example, the Children's Health Initiative was governed by an informal policy group consisting of those three constituencies for 15 years. We also have worked hard in this county to maintain public support for these goals. When we had a bond measure on the ballot in the county in 2008 to rebuild the main patient care building at Valley Medical Center, it passed with 78% of the vote. So when you look at this history, moving towards this coverage initiative was not something brand new, something that people didn't expect. This initiative to deal with the people ineligible for Covered California was widely perceived as the next step in a public policy direction that we've been moving towards for a long time, and that an existing coalition had long viewed as an ultimate goal. So let me tell you a little bit about the structure of the program that we put together. We call it the Primary Care Access Program, or PCAP. I apologize we didn't come up with a more exciting name, but that was all we could come up with when we needed to make a final decision on the name. It's a coverage program, not a licensed insurance product. It only provides care within a specified network in Santa Clara County. It's not usable outside the county. And its focus is to provide regular primary care, including preventive services, and specialty care and inpatient care when those are needed. The network in the county is the community clinics. There are about 20. They have good geographic dispersion in the county. The county's own clinics and Valley Medical Center, which is the county hospital, and which is located in San Jose. To enroll in the program, somebody has to be a county resident who is ineligible for any other public or private insurance, including ineligible for Covered California. They have to be between the ages of 19 and 64, and they have to be low-income persons. The program is administered by an already existing agency of Santa Clara County. That's the Valley Health Plan. The Valley Health Plan manages a commercial plan, a commercial insurance plan for county employees, and also has a Covered California plan that is available to anyone who's eligible for Covered California, and they are administering the new coverage program. The services that will be provided. First, everyone who joins PCAP gets a membership card, which our focus groups indicated to us was something very important to potential enrollees. They want the card. They believe the card indicates that they are not a second-class recipient of health care, but a first-class recipient. With that card, they will be able to present at community clinics. One of those will be their medical home, and they will be eligible for a wide variety of primary care services. You can see the list on the screen. Basic office visits, preventive care, lab work, coordination of care. They'll get a medical home, etc. If they do need specialty care, that would be provided at Valley Medical Center. That will also be the site of inpatient care. In their access to Valley Medical Center, they will be able to receive any kind of inpatient or specialty services that any other unsponsored patient who shows up at Valley Medical Center would be eligible for. Valley Medical Center has a very robust set of specialty services. It has an open door policy and provides high quality care for people who present either at the ER or through referral. The advantage of this program in terms of inpatient and specialty care is that it's going to be combined with the primary care in a medical home, so that there will be a comprehensive set of health services that people will be eligible to receive. Pharmaceutical products will be available either at Valley Medical Center or through clinics. We'll be using the MAP program or 340B. These will be heavily discounted pharmaceuticals. We expect that in no case will anyone really be spending more than $20 for prescription, and in many cases much less than that. Now, there will be some services that aren't covered. Those include residential services like residential detox or long-term care, cosmetic surgery, weight loss surgery, etc. These are services that are not routinely provided by the health and hospital system to other patients as well. The question of financing the program is obviously an important one. And to understand our financing approach, you need to know that our PCAP program is, in relationship to financing, actually a combined program. It's the PCAP program plus the county's existing ADP program, ability to pay program. And we do the linkage because we want the county to continue to be able to receive the funds that it currently gets from a variety of external sources for providing care for unsponsored patients. But when someone signs up for PCAP, they are automatically signing up for both PCAP and ADP. And from the perspective of the patient, this is a seamless experience. So there is back office work if someone gets a referral from a clinic and goes to Valley Medical Center, that the funding is ADP funding, but as far as the patient is concerned, they showed up at the specialty center and presented their PCAP card to handle the cost of the care that they're going to receive. Our target goal for year one is 5,000 enrollees. Candidly, that's an arbitrary number. We weren't sure exactly how easy or hard it was going to be to enroll people. If it turns out that enrollment skyrockets, we'll go back to the county and ask for the target to be expanded. The clinics will receive a monthly grant of $28 per enrollee per month from the county to cover their costs. That $28 per enrollee per month times 5,000 costs about $1.7 million. The specialty care and inpatient care will be absorbed by the health and hospital system budget because since we have an open door policy, the county would be providing care for those people in any event. It will just be doing so now in a more coordinated way to provide a comprehensive care package. Obviously, we hope that as preventive care becomes more available to this population, we will see the cost curve bend in the future as patients are able to get more early intervention and not wait until illnesses become acute before they seek care. The sources of revenue are multiple, but the primary ones are tobacco tax revenues and Measure A revenues. When we adopted the Children's Health Initiative back in the year 2000, the county made available several $1 million of tobacco tax funding to pay for those kids. We no longer need that because the state has finally agreed to move these children into Medi-Cal. So that funding is available for the new coverage initiative, and also In 2012, the county passed a 1/8 cent sales tax increase. It's a general sales tax increase, but much of the campaigning for the program was done by health advocates. They made it clear to the voters that one of the primary service areas of the county is health services, and the County Board of Supervisors acknowledges that that should be one of the major areas of expenditure for Measure A funds. As I'd mentioned earlier, this is a brand new program, so we want to make sure that we have the capacity to improve it if necessary. So we will be working on feedback mechanisms as the program develops. We'll be using surveys and focus groups to find out from people who sign up for the program whether it's providing services that meet their needs, and if it isn't, we will use our collaborative processes to be able to make adjustments. In terms of the actual enrollment procedures, we are going to be doing what we call in-reach. Initially, most people will be signing up at community clinics. When they show up at a clinic for episodic care, they'll go through screening, and if eligible for PCAP, an enrollment counselor will be there to help them do the enrollment process. The application will then be referred to the county's patient access department, where it will be reviewed. Assuming it's approved, it will then be forwarded to the Valley Health Plan, which manages the program, and Valley Health Plan will send the new member a welcome packet. I would just conclude with one piece of advice to groups or jurisdictions that are considering moving in this direction. Starting a new program, even with the extraordinary background of collaboration and goodwill that we have in Santa Clara County, is challenging. You need a dedicated team with staff resources to manage the implementation process. IT systems may need to be adjusted, personnel need to be trained, contracts need to be drafted and signed. You may have to adjust your administrative systems. There's a lot of work to do. So that should be the expectation of anyone who wants to move in this direction. It's certainly worth doing, but being prepared is likely to generate better outcomes. So let me turn it over to Bonnie now.
Great. Thank you, Bob, for those thoughts. So let's turn now to Cynthia to tell us what's going on in Los Angeles County.
Good afternoon, everybody. Again, Cynthia Carmona with the Community Clinic Association of Los Angeles, and I'm going to be talking about the creation of our program down here, which is called My Health LA. So if we go to the first slide there, we did create it in the fall of 2014, and actually our discussions on the project began in 2011. We've had a very good relationship with our Board of Supervisors for a pretty long time, and have been involved in what was historically called the Public-Private Partnership Program, which began back in 1994. So for a few decades now, they have been providing us with funding for visits for those that were uninsured. And so the historical investment was $54 million, but when we morphed it into My Health LA in 2014, that investment was increased to $61 million. And so in 2011, it was a per visit payment, and we began talking to the county about payment reform in the My Health LA program and how we could go to a more value-based system. I already mentioned the program that started in 1994 that provided that limited funding. But when My Health LA was finally created, it actually became a totally new program that was enrollment-based and actually shifted to capitated payments for the providers in the program. And so it was our first foray into an actual enrollment of these folks and those capitated payments. So what really began as a payment reform discussion in 2011 over the years morphed into the creation of a totally new program for LA's undocumented. So in talking about the services that are covered, I know Bob talked about it just now with what was going on a little bit more up north, and it's actually pretty similar in terms of the services that are covered. It's basic primary and preventive health care. I think it's important to note that includes labs and radiology, as well as durable medical equipment, and those have been some interesting topics of interest since the creation of the program. It also includes medications, and these medications, any prescriptions that are written or provided to folks in My Health LA, they are not to be paying any kind of share of cost for those. So those, the county is, going to be paying for all of those and has been paying for those. It also includes DHS specialty care, and so again, similar to what Bob was talking about, that is actually funded through the county's own funds. If a patient in My Health LA needs specialty care, they are referred to a county facility where it's kind of paid out through ATP, similar to what Bob has up north. It is also covered emergency and urgent care at DHS facilities. There's also a dental component, which is actually a separate program referred to as My Health LA Dental. So it's interesting, if you look at the patient handbook for My Health LA, it actually says that dental is not a covered service, but that is because the dental component is paid out through a separate program. It's financed at $5 million total, and it provides limited basic dental care for uninsured folks in LA County. So if you qualify for the My Health LA medical side, you would also qualify for dental services should you need those. You would just have to know to do that separately with your clinic. And we are looking at adding substance abuse services, and that is coming on July 1st of this year. So that's coming up pretty quick, and I'll talk a little bit about that. I do think it's important to note, again, a lot like Bob, the county prefers to refer to these as covered services rather than benefits to avoid any risk of falling under Knox-Keene, and so that was something that was a big consideration as we move forward with the creation of this program. So moving on to the concerns about those covered services, again, labs and radiology is something that we hear about from the members to this day in terms of cost and whether or not the current capitated rate is actually covering that cost. I think most folks would say no. And so that's something that we're struggling with, as well as the durable medical equipment side. So when we talk about DME, the county really likes to refer to things like diabetes test strips and things like that, but as a lot of folks probably on this call know, DME refers to a whole range of equipment, including things like wheelchairs and stuff of that nature. So we are kind of in ongoing discussions with the county about what the clinics are and are not expected to provide, because I think, and we've gotten some general agreement from county leadership that, the wheelchair stuff, that kind of thing, they certainly wouldn't necessarily expect the clinics to pick up. Things like the test strips and of that nature, they are looking for the clinics to provide, and so really looking at clarifying what is meant by DME. There is confusion over the dental service component. So the handbook says dental is not a covered service. I've been in meetings with My Health LA beneficiaries or participants who are completely unaware that they can get dental. And so we have to do a lot of outreach, a lot of marketing to patients so that they understand that that is a covered service. So marketing is a big piece of that. Also, when we began the dental program in 2014, allocations and the financing of that was not done well, and there have been some reforms to that that I can speak about in a little bit that have improved the take-up of the provision of dental services in the program just over the last year. So that's a positive, but there's been a lot of confusion over the provision of dental services thus far in that program to date. My Health LA launch of pharmacy phase 2. So I talked about medications being a covered service. Currently, the clinics get paid kind of an additional capitated rate of $4 per member per month to cover medications, but there was a stipulation when the program was created that we would create a phase 2, which is actually a highly complicated way of providing medications to the population. DHS was very interested in benefiting from the 340B discounts that the clinics can garner. So we spent a lot of time with 340B attorneys and talking to third-party administrators, and we're currently working on that to this day. So for the last year and a half, we've been talking about how to implement that. It's a hybrid dispensary, clinic pharmacy / also retail pharmacy network that's being created. However, it does require dispensaries to report data daily to the county's pharmacy third-party administrator. And so that is something that we're working on a lot over the last several months. The operations of that, how much does it cost to put in systems that can actually pull up reports that have all of the fields that the county's wanting on those patients. Their argument is that if a MyHealthLA patient shows up in a county ER, they want to be able to go into the system and know what medications those patients are on or have been prescribed as recently as 24 to 48 hours before. And so there are a lot of issues with that, as I'm sure a lot of folks on the phone would understand, and we are working through those. And because of the complicated nature of launching phase 2, that launch has been delayed indefinitely. So we were supposed to launch that back in January. It got delayed to April 1st, and even since then, because of the complex nature, it has been delayed indefinitely until we can figure out a lot of those operational complexities that have to be determined. So, and that'll likely be, it'll be some time before that is launched. So, very, very complicated piece. On the financing side, so I mentioned in the beginning, we began with a $54 million investment. That was kind of, we started with the baseline from 2013 from our prior program, the prior level of investment that the county was providing to clinics to provide care to the undocumented. And when we started talking about how we were going to finance this, we did enter into a pretty lengthy and complex negotiation with the county. So discussions included what's the desired size of the program, what are going to be the eligibility requirements, what's going to actually be the MGF rate, so the cap rate, what is that going to be? And so just to kind of address those three things, the desired size of the program, we did hire a consultant to look at historically in our county program how many folks were utilizing that on an annual basis, and we came up with a little bit over 100,000. However, there was, I think, a general sense all around at the Board of Supervisors level, the DHS level, at the clinic level, to get as many folks into the program as possible. In LA County, I think the UCLA UC Berkeley labor study that came out a few years ago estimated there were over 400,000 undocumented folks in LA County. So obviously we wanted to get as many of those folks in as we could. And we ended up settling on 146,000 people. So a little bit more, you know, significantly more, I think, than we had been doing in the past in terms of capitation. Eligibility requirements, we set that at the Medi-Cal income level, so 138 FPL. The monthly grant funding rate discussion was a lot of back and forth. We did end up hiring some DC-based attorneys at Feldman, Tucker, Leifer, Fidel to assist us with that discussion. I think one of the key things that came up was, you know, whether the federal you know, FQHC grant funding can be used to subsidize the MyHealthLA program. So there's a lot of discussion about whether that's okay or not. Our lawyers came back and said that federal law doesn't intend for that to happen, and also helped us with valuing the services that the clinics are providing for these patients. We also had to discuss with attorneys the 340B program at length, and as I mentioned, we're still talking about that. I still have those attorneys looking at various contracts that the county wants us to engage in to make sure that they are 340B compliant and that there's no risk of diversion and that adequate auditing is happening on inventory. So we spent months on many meetings, including with the Board of Supervisors, to reach agreement on it. Lots of meetings with county council and things like that. So we began with a significant historical investment of $54 million, and really, again, like Bob up north, saw it as an opportunity to improve the financing and grow the partnership even further, which I think is what we did. So moving on to the final rate agreement, I already started talking about this. We were able to increase the investment to $61 million to cover 146,000 people. Came out with a $28 what we call monthly grant funding rate, and that's capitation, so $28 per member per month, with an additional $4 pharmacy cap rate per member per month. And again, that will change once we figure out this pharmacy phase 2 piece and that goes live. The county will be paying for those drugs directly or indirectly, depending on how our 340B system will work with that. We phased in the cap rate after a 6-month enrollment period, and so one of the sticking points with the county was they wanted to start the cap rate on day 1, which didn't make a lot of sense to us or our finance consultants, and so we were paid a per visit rate of $105 per visit for the first 6 months until April 1st of 2015, when we switched to the cap rate. And one of the things that really helped us seal the deal on the negotiation was the county agreed to provide a COLA adjustment to the rate in years when a COLA was awarded to county employees. And so that takes effect this year. So we will be looking at revisiting that COLA with the clinics. Obviously, that's going to be a nominal amount of money, but as you can imagine, every little bit helps. So heavy involvement from the board offices to get to that final agreement. So what's next for us? We are actually currently in the process of doing a financial analysis on the impact of the MGF to clinics compared to the prior county program. So how are clinics looking financially on this program compared to what they were getting before? We are finding that folks are having a harder time. So we'll be providing that information to the board offices since they are interested in that. I think the other thing that I do want to note on this is the impact of SB 75, so the transition of children into full scope Medi-Cal, the undocumented children. So we're going to be pulling about 10,000 kids out of My Health LA and hopefully getting them all onto Medi-Cal. And so we are actually working with some offices to talk about taking a look back at our cap rate and the assumptions that were made there to see if we want to revisit those assumptions to potentially account for a higher acuity population now that we're pulling the kids out of that program. So it is providing an opportunity for us to go back and take another look at the reimbursement those clinics are getting. Again, we are in discussions with LA County on substance abuse services implementation. So that will largely take advantage of the county's substance abuse service network. They are doing a lot of work, as folks are probably aware, under the new drug medical ODS waiver that took place at the state level. So LA County is redoing their substance abuse network, and they actually were able to come out with some additional resources from that, and that's kind of how we're able to add this particular benefit. So it'll be kind of a pretty simple referral process. We're working with the clinics to develop those referral networks to make sure that that goes smoothly. I think on phase 2 implementation, again, that's ongoing, not clear when that will be finalized. And there's been a little bit of underspending. So we haven't yet actually reached the 146,000 mark. We are at roughly 139,000 folks in the program right now. When we went through our first renewal period last year, we saw a dip of about 7,000 folks because they all became, you know, it was all, the renewal dates all came up at the same time, and so that was a big challenge for the clinics. But we made that back up, and we're back up to where we were. Now when SB 75 occurs, that number will go back down again. We'll see about a 10,000 drop there, and then we will try to inch that back up. So because of that, we're not at the cap yet. We have a little bit of money left over. We're talking about some one-time spends for that, potentially allowing the kids to stay on for just a few extra months to make sure that the SB 75 transition goes smoothly. But also, if they need any infrastructure enhancements to assist with the pharmacy phase 2 implementation, that will be costly for the clinics, and potentially we could use some of that funding for that as well. So we're in discussions with the Board of Soups on all of that, and I will just kind of leave it there and turn it back over to Bonnie for our next speaker.
Great, thank you, Cynthia. Before I turn it over to David and Norma to talk about what's happening in Fresno, I just wanted to remind everyone to submit questions that you have in the question window on your screen. So with that, David, I'll turn it over to you to talk about what's happening in Fresno.
Great. Thank you very much. To kind of tell the story of Fresno, we have to go back a few years prior to implementation of the Affordable Care Act. And Fresno County had provided services to the medically indigent through a comprehensive contract that it had with community medical centers. It was a contract that was established in 1996 when the county transferred its county-owned hospital to the community medical system. This agreement that we had was a fixed cost 30-year agreement requiring community medical centers to be essentially the medically indigent services provider for the entire county, including outpatient and hospital services for the inmates that were held in the county jail. The county used 1991 health realignment to fund the contract, and it was a contract that served about 20,000 individuals each year. It was unique in that it included language from a 1984 injunction that prohibited the county from denying services based on residency. This allowed individuals to seek medical care regardless of citizenship status. The annual cost to the county was about $21 million, and that cost had an index that was based on the CPI. But the cost over the first 15 years of that contract for providing medical services grew dramatically to almost $100 million. With the passage of Assembly Bill 85 and the follow-up bill SB 90, the county was going to have health realignment dollars, 1991 health realignment dollars redirected to other programs. So we were losing a substantial funding source for that comprehensive contract. So we needed to renegotiate or modify or terminate the contract that we had with community medical centers. And we knew that many of the people that were served were going to be part of the expansion population under the Affordable Care Act, but there was also a concern that there were a number of people who would not meet the residency requirements of the ACA or of the expansion of Medi-Cal. We were concerned about that population and began meeting with partners, our federally qualified health care centers, hospitals, health plans, and county leadership. And we had fiscal impacts associated with this in the 13-14 and 14-15 fiscal year. The Department of Public Health reduced staff, and the County Board of Supervisors allowed some mental health realignment monies to be used to support the community hospital contract after implementation of the Affordable Care Act for the first 12 months. The transfer of mental health realignment was not a sustainable source of revenue to fund the contract, and further cost cuts to the core public health programs we felt would be really irresponsible. These are core programs including tuberculosis control, communicable disease investigations, and so forth. So without a funding source and without a medical system that the county owned or operated, we knew we needed to balance a change in policy. And what it really required was for us as a county program to sit down with all of the partners in the same room and start to talk about what we might be able to do. It took a lot of education of our local elected officials, and it needed to come from multiple voices. We spent a lot of time in hearings explaining kind of where we were at, but it also took a lot of one-on-one meetings with the hospitals and the clinics providing perspective on what needed to happen in Fresno. The team that we had working on the program really focused on what can be done given the situation that we were in. The situation was one that was politically charged with very strong opinions on both sides of the issue with regard to undocumented individuals. The local media weighed in, and we had lots of editorials offered by many folks in our community, kind of spurring on lots of discussion about what options should be made available. But I think that the people who were participating in this really focused on what the patient needs were. And that was an important priority to place on this project, because we knew that the federally qualified healthcare centers were doing a wonderful job of providing primary care, but they could treat people to a point where they had no other choice but to wait to be sick enough to go to the emergency department. That didn't seem to be a good answer. You can advance the slide, thank you. So the current situation was from January to December of 2014, we essentially kept the county's MISP program in place and continued to provide services. And most of the 19,000 patients that we served in MISP were enrolled in Medi-Cal. But we remained concerned, the community remained concerned, and our partners remained concerned about what would happen to individuals who sought care at the primary health care centers, but where the medical services provided there were beyond what they could provide, and where we needed specialty care. So we devised a system, an interim system of care, that requires an individual to enroll in Medi-Cal first. And that was an important step that we had to take. And the patient would have to exhaust all other options available to them. They would enroll in Medi-Cal, and in many cases, individuals qualified when they did not think they would qualify. We had not done outreach education in the county with regard to the PRU-Call provisions of Medi-Cal, and so a number of people were able to qualify for that program. The individual needs to seek primary care services at a federally qualified health care center, and if the health care center, the need for medical care is beyond the scope of the health care center, then the physician needs to just do an attestation to the need for further care, and the individual provides just a certification, a signed certification of residency in Fresno County. Then they're referred to a specialty care clinic. And so we worked with the partners to devise a way where the providers could be reimbursed. The county had set aside $5.5 million as a beginning funding source for this program. And we established with an agreement with a medical billing company, Advantech, located in Fresno. They handle the claims. So the clinics refer to our specialty care clinic at the hospital. And then as services are being provided, the bills are sent to Advantech. They confirm that the patient has been enrolled in the program and that the services were provided were appropriate, and then the provider gets paid. The patient front door is the federally qualified health care center or the hospital. And as I mentioned before, enrollment in Medi-Cal is required. That was initially thought to be a substantial stumbling block, but our DSS partner really has done a very good job of making sure that the clinics can enroll people, but then also they have a backdoor phone line to address any urgent needs that we may need to address with regard to getting people enrolled in Medi-Cal. Any covered specialty services beyond the scope that the FQs can provide are referred to Community Medical Center for treatment, and services are provided and claims are processed in this program called non-resident specialty care as the payer. The providers are paid at the Medi-Cal fee-for-service rate. And the State Department of Healthcare Services will allow these costs to be claimed in the health realignment true-up process as part of Assembly Bill 885. So the current situation is that the clinics are doing a very good job of continuing to provide primary care services, and they're making referrals to the community hospital specialty care clinic. The screen through Medi-Cal is working right now, but I believe that's both a path, but it's also a hurdle. We've heard from some of our folks in the community that some undocumented individuals are concerned about the amount of information that's required to be disclosed on the Medi-Cal application, but I think we're doing a good job of overcoming that. And we also recognize that this is not a permanent solution. It was really truly a Band-Aid on a system that was already quite stressed. But the partners have worked together to kind of evaluate where things are at, and we have a monthly meeting where we are convening partners and trying to refine the system as we go forward. You can advance that slide. And that's what I just spoke about. So what I would like to do at this point is to turn the presentation over to Norma Forbes, one of our key community partners, to discuss the lessons learned and how the process is going.
Thank you, David. I'm going to be summarizing with the last couple of slides here on what we have learned in terms of our lessons from working with this change in Fresno County, some of the successes and challenges. And firstly, in terms of successes, I think that it's really important to identify that we are now making forward movement on the uninsured and the undocumented. And as David explained, we had about 15 years of the status quo, where we were not actually doing much communication and hardly any collaboration over this issue. So this is a tremendously different environment that we have now with this new fund available. We do have some access to specialists that is occurring, not as many as we'd like, but we do have people getting to specialty care now. We do have a broad stakeholders group involved. I'll talk a little bit more about that on the next slide. We have education and training that is occurring. We have had education with our stakeholder group on immigration issues. We have educated referral clerks in the clinics, application assisters in the community-based organizations about this fund. And we have lessons learned. We've identified barriers. So some of the challenges, I want to just reiterate that change is slow, particularly when you have multiple organizations involved. It's very complicated to move through that environment, and so we are making progress, but it's at a slower pace than we would like to have. And I want to say that we have made, and David stressed this, we've made one step forward. There are many more steps that we think need to be taken. This is sort of an interim program, and we want to look at a more permanent solution. Money is only one of the issues. When we got this fund, we thought that, wow, all we have to do is just spend this now. This is terrific. And it's more complicated than that. And David identified some of the barriers. The Medi-Cal reimbursement is an issue that for providers that has really become a focal point right now. Gathering data to be able to provide evidence for improvement is challenging, and we are trying to do that, but and it's part of this project, so we are working on that. I just want to say there are many icebergs. David referenced some of the political issues. When you have the county board of supervisors and the state, making a change in that environment is difficult, but then our healthcare delivery system environment is really under a dynamic system change all the time. I mean, there's really no good time to do this, but the environment can actually help create more of a problem sometimes. So for the next slide, please. On this slide, it's like, so where are we going from here? Basically, we're going to be continuing the activities that we've started we come up with some recommendations and improvements that we're identifying. We're currently, looking at the Specialty Care Reimbursement Fund and trying to identify how we can help people to use those funds. We do have a monthly stakeholder group that we will continue to not only share and exchange information and review data, but identify policy options for expansion. We have about 30 organizations that are involved with us on that group. It's very impressive. We're pleased to bring these people together once a month. They are community advocates and agencies, providers, the city, county, state government, policy organizations, health plans, health clinics, hospitals, doctors. So we feel that that foundation of public input is really worthwhile in determining and valuable in terms of determining where we are going with this in making it work a little better and also a more permanent solution. We are also continuing to assess our current services, looking at funding and the gaps that are existing in the process. And the ultimate goal is to present a report to Fresno County Board of Supervisors on recommendations for a data-driven policy and practice. And actually, our intent is to be able to improve care and improve coverage, improve enrollment, improve funding, and improve utilization. So we have big goals, but we feel that we have momentum. Inertia has been overcome. We want to keep moving forward in Fresno County to better serve this population. We know it's going to take incremental steps of improvement, but we are underway. So this is where we are and where we want to be. So with that, I think, Bonnie, that's the end of the presentation. We're ready for Q&A.
Yes, thank you, Norma, and thank you, David, for talking about what's going on in Fresno. Also to Cynthia and Bob for your insights earlier and for taking the time to share your learnings with all of us today. We will now open things up for questions. As a reminder, if you'd like to ask a question, please do so by typing it in the question window on your screen. Unless it's specified for a particular person, we'll distribute each question to the most appropriate speaker to answer verbally. So we have a number of questions coming in, and I might start this first one. I'll direct to you, Bob, and if you can talk a little bit about what services specifically are covered by the PMPM grant.
Yes, the grant covers the spectrum of primary care services that are delivered at the clinics. So the clinics become the medical home. They coordinate care. They provide ordinary office visits, preventive care programs, lab services. They manage chronic diseases, etc. It's specialty care and inpatient services that are not available at the clinics that are provided at the Central Hub Valley Medical Center.
Great, thank you. The next question, Cynthia, is directed to you, and if you could please explain in more detail how the FQHC payments can or cannot be used to subsidize MyHealthLA.
Sure, I'm happy to talk about that. We actually went to, again, our DC-based attorney, because that was an argument we were hearing from the county during rate negotiations as well. You know, you guys already get these 330 grants for this population, therefore we don't have to pay you the full cost of care for this population. And so we worked with Felsman Tucker, and obviously, you know, I can't really read the entire legal opinion they did for us on that. But they went through the code. We did actually also have some offline discussions with some leadership over at HRSA, which was very helpful, to provide some guidance to us that said, you know, we had it on pretty good authority that if there were other programs out there for these populations, that it wasn't HRSA's intention that 330 grant funding be meant to kind of subsidize those programs, or they weren't really interested in setting a precedent where programs are being set up to pay clinics less than cost because, oh, 330 is picking up the rest. So that's kind of what we went back to the county on. And I'm not going to say that it resulted in a really tried and true, fast and sure policy on that, but I think it did end up making a big difference in the final MGF rate that we came up with, which was 28. You know, in the beginning of the discussions, we were talking about 23, and that's really where we started to come in with some of this other information and really kind of convince the county to give us a bump up on that.
Great, thank you. David and Norma, I think these questions can be best directed to you. We had a question if you could clarify who in Fresno is paying for primary care services, and then also if you can clarify how many are actually enrolled in your program.
So in the primary care is handled by the FQHCs, the Federally Qualified Healthcare Centers. And I think we have in Fresno County about, we have three providers, and I think there's about 29 doors if you count the different offices throughout the county. They are providing the primary care services. The enrollment process moves every day. We have about 100 individuals that we're tracking currently that are needing specialty care. But what's happening is as they are moving through the process, many of them are qualifying for Medi-Cal. So there's some that end up in the non-resident specialty care program and then move into Medi-Cal. So the number moves really on a daily basis.
Great, thank you. This question I think may be open to any of you, so I will pose it in terms of how did you decide what specialty care to cover, and sort of if this specialty care incurs long-term follow-up treatment, how did that factor into what specialty care you determined you would cover? So who might want to start?
Well, this is Bob.
I can offer what we... Go ahead, Bob.
Okay. I mean, I'll start. It was relatively simple in our county. The county hospital already offers a broad spectrum of specialty services. We've built up that health and hospital system over decades, and so that's the set of services that we make available to anyone who signs up for the new program.
Great. David?
In Fresno, we had an existing list of specialty care services that were part of the medically indigent services program, and so we just used that existing list that had been in place since the 1996 contract was put in place with Community Medical Center. So it was basically the same scope of services, and it does include long-term care. However, it is we do have a fiscal cap that currently our contract is at $5.5 million. So we tell patients it's not a forever guaranteed entitled benefit, but we will provide services as long as we have the funding.
Great. Cynthia, any response?
I would just say, kind of similar to what others have said, is that the county has historically been providing specialty care to our population. It was actually some of our clinics were providing limited specialty care services, and it was determined through the course of our negotiation that from here on out, all specialty services would be done at DHS. And so that's what happens. And if a patient goes to DHS for those services, it's paid out separately through their own budget to do that, and they need longer-term follow-up on the specialty side, they remain with DHS. I would say that there is an interesting component to our program that DHS refers to as NERF, wherein they identify patients in their specialty system that are now stabilized and have identified can return to primary care, and we're working on a program where those patients are kind of re-referred back to primary care and enrolled in My Health LA, and they come back to the clinic.
Great, thank you. Bob, this question is directed to you. If you could clarify when PCAP will come into effect, as you outlined your enrollment target of 5,000, and then also, is there potential for the program to expand to other counties like Merced and Stanislaus?
The program just opened a couple of weeks ago, so it is in place. We have about 250 people signed up in the first couple of weeks. As I indicated, the 5,000 is just sort of a placeholder. As we continue enrollment, we can expand that number if we're enrolling more than that. We estimate there's about 50,000 people in the county who are ineligible for Covered California and would be potential enrollees into this program. No one here has actually ever thought of the idea of expanding the Santa Clara County program into another county because it's a coverage program that's based on our network. Somebody could use a similar model in another county, but this is really one that's designed to take advantage of the specific set of institutions and services that we've built up in Santa Clara County and use those economies of scale.
Thank you. Cynthia, this question is for you. You referenced the analysis of the financial impact on LA clinics. Are there any preliminary findings out yet that you can share with us, or if not, do you have a timeline for when those might be available?
Yeah, we don't have any preliminary findings right now. Our finance consultant is in the midst of gathering that data from the participating clinic cohort. I can tell you that I have clinics evaluating the impact on a one-on-one basis, and all of those have come to me to say that they're not doing as well. Our estimated completion date for that report is by June 30th of this year, and we expect to kind of provide that to the board for ongoing discussion.
Thank you. David and Norma, a question related to one of your bullets around you identified patient needs really became the priority in setting up the program, determining what services would be covered. Can you talk about what strategies you used to elevate the patient voice as you were developing the program?
We didn't need to do much. There was a very local and prominent voice in the community. The Building Healthy Communities initiative in our community was very collaborative and brought forward a number of issues that members of our community were facing. And so there was a very organized group of the community that provided very good voice and very good input. And then I must say that the federally qualified healthcare centers, the representatives from them, didn't bring to the table the talks about, how they were going to get things paid for so much. It was about, these are the needs of the clients that we are currently serving. This is the conditions that we are facing. And they had made great strides in providing, new physical infrastructure and expanded programs at the primary care level, and they really needed for us to focus on specialty care. So I think that the voice came both from organized community members and the FQHCs.
And this is Norma, we're trying to keep those voices in our broad stakeholder group. We do have all of the FQHCs, the hospitals, and the community advocates involved with us on these monthly meetings. So as I had indicated, that's a very important voice to us to continue to listen to.
Great, thank you. A question posed for any of you to answer, which is, do you enroll clients in emergency or limited scope Medi-Cal when they need those services that are covered by that program?
Fresno answers absolutely yes.
Yes, in LA.
Yes.
Great, thank you. Cynthia, a question for you. There's interest in learning more about sort of how the conversation to include substance abuse services was initiated and what conditions allowed for substance abuse services to be included as part of the program.
Sure. I think there were a couple of things that led us to the inclusion of substance abuse as a covered service. The first being last year, the LA County Board of Supervisors took a couple of significant steps to improve and integrate the health system here in LA. They created a health agency, which is kind of an agency that oversees Department of Health Services, public health, and mental health all together in the interest of better integrating the provision of those services to LA County residents. In addition, they are rebuilding LA County Central Jail and have created a new Office of Diversion because they are interested in making sure that folks aren't being put into prison who could benefit from community services. So folks who maybe have substance abuse issues, have mental health issues, could maybe benefit more from receiving services than obviously being put into the men's jail. So they created the Office of Diversion for that, and I think the third thing would be the state drug Medi-Cal ODS waiver that took place a year and a half ago, that process. And so the county is in the process of redesigning their drug Medi-Cal network, and I think are interested in just making sure that those services are available to all of the residents in LA County. And as a result, I mentioned there were some additional resources identified as a result of redoing that network, and they determined that they were able to accommodate the entire My Health LA population to provide those services for them. So it was a confluence of a lot of things that I think led up to that.
And a follow-up question to that, does the Office of Diversion collaborate with the Veteran Treatment Court?
So I don't know, because the Office of Diversion was just created, like I want to say like 4 or 5 months ago. So I'm sure that those discussions are happening, but I'm not, I actually don't have an up-to-date kind of progress report on the Office of Diversion at this point. I'm not even sure yet if they've appointed a director of that office, although that's possible.
Thank you. So this question is directed for all of you, and I think I'll ask Bob to respond first. As you look to financing and the rate development in your programs, what data did you need in order to inform the rates and financing, and what information was most difficult to get in terms of data that you needed? Bob, do you want to start?
Yeah, the rates were essentially negotiated between the community clinics and the county. And there was initially some disagreements about what the rate would be, but what we really agreed on was a concept. And the concept was that we wanted the transition to this new program to be one that at the least did no harm to the community clinics, and it was okay if it was beneficial to the community clinics, because we have this strong relationship and rely on them as a first line of medical services delivery in the county in terms of the geographic diversity and population diversity of the county. So we came up with a number that was probably erred, if at all, on the side of being positive to the clinics, with the understanding that as the programs gets up to scale, we'll take another look and see what the data shows. So this is a transitional number, and I think that philosophy shaped it as much as any of the specific data points that were discussed in the negotiations between the county and the clinics.
Great. Cynthia, would you like to offer anything?
Can you repeat that really quickly, Bonnie?
The question was around the data that you needed to help inform the rates that you set, the financing of the program, and what was most difficult to get, and sort of how did you overcome getting that data?
Yeah, so that's really interesting. We were engaged in a couple of initiatives to gather that kind of data between 2011 and 2014, and we found that it was challenging. The data that we were able to get from the county was not stellar. We were able to get utilization data, which was very helpful in helping us reach an agreed upon capitation rate. I will say that we began to have some discussions about acuity, but that became very difficult because historically DHS had only required the reporting of one diagnosis code, or some clinics were only reporting one diagnosis code, so it was really difficult to tell if patients had, several chronic conditions, which, as everyone knows, is very common in the clinic population. So we really couldn't get that acuity data to the level that we wanted. But yeah, so we used the utilization piece. I think something else that has become, that has been a sticking point over the years has been the number of member months as well. DHS consistently likes to assume 12 member months, and our finance consultant doesn't love that. So, but we weren't really able to get any good data on that either before we launched the program.
Thank you. David, anything to add?
We were flying blind on data. We looked for ways to be able to cost the program in a way that would be based on what the history was of the population served, but we just had a very difficult time. We did not have good data systems in place to carve out that population that would not be served under Medi-Cal. So our kind of default was to use the Medi-Cal fee-for-service rates. I can tell you that that is an area that Norm and I are going to continue to work on. But we're told by the providers at this point the issue in terms of access to care is not so much about the rate paid, but more about just the lack of specialists.
Thank you. And thank you all for your questions. We're now out of time for today. I want to give a special thank you to Bob, Cynthia, David, and Norma for your insights and sharing what you've been learning with us all today. We encourage you to connect with one another outside of this webinar to continue learning from each other. After this webinar, we will be sending out an email with a link for a brief evaluation survey of today's webinar to help us better plan the next 2 webinars. We will also be posting the recording of this webinar and the March 30th webinar in the next couple of weeks. If you haven't already, we have 2 remaining webinars in this series. The next one will be on May 17th from 1 o'clock to 2:15 on eligibility and enrollment, and our final webinar will be June 15th for measuring quality for program improvement. We hope you will join us for both of those webinars. This concludes today's webinar, and have a great rest of your day.